Hello, everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. I'm Andrea Bianchi, and I'll be the moderator for today's session. Our speakers are Rosalind Abdool and Eoin Connolly, and this seminar is entitled Involvement of the Consent and Capacity Board in Challenging Ethical Impasses Around Substitute Decision-Making. Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now, it is my pleasure to introduce today's speakers. Rosalind Abdool is an ethicist at Trillium Health Partners in Mississauga, where she also serves as the alternate vice chair on the Research Ethics Board. She is currently vice chair of the Canadian Association of Practicing Healthcare Ethicists, and is an adjunct lecturer at the University of Toronto in the MHSC in Bioethics program at the Dalla Lana School of Public Health. Eoin is an ethicist at Trillium Health Partners and has been for the last 10 years and embedded in the critical care program for the last 4 years. Eoin is also an adjunct lecturer in the Master of Health Sciences and Bioethics program with the Dalla Lana School of Public Health at the University of Toronto. Eoin's research interests include ethical issues in end-of-life care, critical care, and organizational ethics. Now I'll pass it over to the two of you.
Great, thank you very much, Andrea, and welcome everyone. We're very thrilled today to be able to present on this topic to you, and we're excited to not only be able to provide you with some information on the involvement of the Consent Capacity Board in challenging ethical impasses around substitute decision-making, but hoping that in the Q&A we'll be able to learn from you as well and hear about some of your insights and experiences with the CCB. So just to kind of situate our presentation today a little bit, both Eoin and I, as Andrea mentioned, are ethicists at Trillium Health Partners. And we're going to be talking a little bit about our experiences as ethicists, working in complex situations with teams, families, SDMs, and how we facilitate some of the conversations around what's in the best interests of a patient or what's best for a patient, and how some of those conversations go, especially prior to considering involvement with the Consent and Capacity Board. This presentation is a slightly longer version of a presentation that we gave to the Canadian Bioethics Society last year, and we had some great feedback and thought it would be a good presentation for the JCB community as well. So to get us started here, I will say that we have no conflicts of interest to declare. Our objectives for today's presentation are as follows. We want to discuss some strategies to resolve STM conflicts and to hopefully avoid unnecessary adjudication processes. We'd like to identify some types of cases for which an application to the CCB may or should be made, and understand a little bit about the role of the CCB, including preparing for a CCB hearing from an ethics lens. I will add as well that we're going to focus probably most of our case examples on treatment decisions, just given our experience as ethicists in the acute care setting. However, the CCB can be used in other contexts as well. So admission to a care facility and personal assistance services as well. And just another quick note that, of course, we're not here to provide legal advice as ethicists. We're not lawyers, and to encourage you to seek legal supports and expertise around advice that you need in specific situations. So very broadly, what kinds of scenarios are we talking about? We're talking about ethical concerns related to substitute decision-making, and we're going to get into much more detail around these two specific questions. The first one is, who is or ought to be the patient's SDM? And I'll walk you through the SDM hierarchy as per the Healthcare Consent Act in Ontario, and then talk about some different alternatives to how that can play out. And then, of course, the second question is the SDM making appropriate decisions for the patient? So most folks who are watching today probably have an understanding of the STM hierarchy here in Ontario as per the Healthcare Consent Act, but we thought it would be important to just walk through what the STM hierarchy is so everyone's on the same page. If we have a patient who's deemed to be incapable, and oftentimes, as I mentioned, it's around a treatment decision in acute care setting, then the person who is highest on the hierarchy, who also meets the STM requirements under the Healthcare Consent Act, is the SDM, or there can be also multiple STMs if there are multiple individuals who are listed on one line of the hierarchy. The first three levels of the hierarchy are legal appointments. So we have a guardian for a person, which is typically an application that goes through the court process, an attorney for personal care, a document that a capable individual completes to assign someone to be their SDM, and then the consent and capacity board representative, which we'll talk in quite a bit more detail throughout the presentation. The rest of the hierarchy is really a focus on default SDM, so who would typically be the default person to make decisions on behalf of a capable person, and they are listed below. There's lots of content here that we could talk about in terms of definitions and variations, but we'll save that for the Q&A if there are some further questions or perhaps another presentation. If there is no one on the hierarchy that is listed that's highest or meets the SDM requirements, then in Ontario, we're fortunate to have the Office of the Public Guardian and Trustee who will act as the SDM of last resort. I'll also highlight what some of those requirements are. So not only do you have to be the highest person on the hierarchy, but you also have to meet the requirements of being capable oneself to be an SDM, at least 16 years old, unless you are also the incapable person's parent, not prohibited by court order or separation agreement from having access to the patient or giving or refusing consent on behalf of the patient, must be available, and this is within a reasonable amount of time pending the decision that needs to be made, and are willing to assume the responsibility of giving and refusing consent. So on to how should SDMs make decisions. SDMs, according to the Healthcare Consent Act in Ontario, should make decisions based on, first, any prior expressed capable wishes that are applicable to the current situation, or barring none, the patient's best interests. And best interest takes into consideration the information that the healthcare professional has provided, so risks, benefits, alternative courses of actions, consequences of not receiving treatment, and so forth. I will say, as an ethicist working in an acute care setting, sometimes I've been told by providers, it's the SDM, we have to respect the decision that they're making. They can make any decision and we have to follow that decision, but it's an important time to remind folks that there are obligations for SDMs under the Healthcare Consent Act to abide by these principles for substitute decision making. And there are processes that we can follow to ensure that SDMs are following the principles for substitute decision making as well. Our role as ethicists often involves facilitating some of those conversations upfront so that we can hopefully resolve any issues prior to thinking about or even needing to go to an independent body like the Consent and Capacity Board. So let's dive a little bit more deeply into these two different components of making decisions. Prior expressed capable wishes. So what do these actually entail? It's quite interesting in our experience learning from some of the reasons that are publicly made available on the CanLII website, what actually constitutes a prior expressed capable wish. So when we think of things like advanced care planning, advanced directives, living wills, sometimes there's wording in there that might be a little bit vague, like no heroics, or I don't want any tubes, or something like that. And those very general, generic expressions probably wouldn't be considered a prior expressed capable wish. From our understanding, prior expressed capable wishes really need to be quite directive in terms of being applicable to the situation, really acknowledging the context of the situation, and that one could have anticipated that they would have been experiencing the complications, for example, or the general scenario that they find themselves in, and being able to make a wish that is, again, very applicable to that context or circumstance. So when you think of a disease or illness trajectory that might be a little bit easier to predict, for example, where you know what to anticipate, then in that context, someone might be able to have a more clear prior expressed capable wish when they can actually talk to what was expected or anticipated and have that wish be made very clear after having a good, fulsome conversation, for example, with their healthcare provider. then that becomes more akin to a prior express capable wish, as opposed to more vaguely a value or a wish that someone might have expressed in terms of their best interests. Another interesting learning point that I came across more recently in a hearing and a reasons that was available very recently was that just in the case that someone follows a particular religious doctrine doesn't mean that that is a prior express capable wish. So I'll read out an interesting excerpt from reasons that I found quite helpful myself. So the panel also determined that X's devout adherence to Islamic doctrine did not rise to the level of a prior express capable wish. To adopt that reasoning would be to remove agency and autonomy from a devotee of a particular faith. Even a person who is strictly and determinately religious should be allowed to stray from the tenets of their faith in exceptional circumstances. A person whose faith advocates for life-sustaining measures may ultimately change their mind if they are in extreme pain, for instance, or they feel that they are a burden for their loved ones. So very interesting that being part of a particular faith base doesn't necessitate a prior express capable wish. Doesn't mean that there isn't one or there couldn't be one, but that was certainly something that came out of a CCB ruling. And the importance of focusing on individuals and being able to make decisions autonomously for oneself. An analogy would be for MAID, for example. Anecdotally, we've had folks who come from very particular faith backgrounds, faith doctrines, who have chosen MAID at the end of life, even though that wouldn't necessarily adhere with the general philosophy of the faith. So keeping that in mind in terms of a prior express capable wish as well. So let's keep going in terms of a patient's best interests. I will say from my experience, it's probably quite rare to have a prior express capable wish that's applicable to the situation that actually meets that threshold, given that it has to be quite precise and really acknowledge the circumstance that one would find oneself in, which is hard to determine, especially when there's lots of complications, for example, that can come up in an ICU setting. So let's move along to best interest, which I think is the focus of much of the conversations that we have as ethicists around end of life. As per the Healthcare Consent Act, there's several different components that constitute best interests. First and foremost, it's an individual's values and beliefs. And I talked a little bit about what that might entail. So if someone comes from a particular religious doctrine, those values and beliefs might be taken into consideration. Also, some thoughts around who they were, what they enjoyed, what they believed to be good quality of life. And I'll give you some more examples of some of the conversations and some of the questions we might ask as ethicists in family meetings. Wishes that don't necessarily meet the criteria outlined previously, so not prior express capable wishes, but maybe some other wishes. Again, in a recent ruling, there were a few questions that were posed in terms of what constitutes wishes that don't meet those criteria. And some of them were, would it be a wish expressed by a person while incapable, a person under the age of 16, or a general wish that was not applicable to the current circumstances? And I would say, certainly in my practice, we often talk about wishes of an incapable person. And a few examples of that might be someone who is incapable, so doesn't meet the threshold for capacities and able to understand or appreciate the decision-making factors at hand, but is indicating that they don't want to continue with dialysis, for example. So really indicating and gesturing that they don't want to go ahead with that intervention, or even with drawing blood. Again, indicating, expressing through gestures, not necessarily a capable wish, but an incapable wish that that's not something they want to go ahead with. So again, something to take into consideration in the overall calculation. And then, of course, we think about some of the more medical factors to consider, whether the treatment is likely to improve the condition, prevent deterioration, or decrease the rate of deterioration, whether the condition will improve, remain the same, or deteriorate without the treatment, whether the expected benefits outweigh the harms, and whether a least restrictive or less intrusive treatment would be as beneficial as the proposed treatment. So best interest really is this holistic picture of a patient's context. It's not focusing solely on values and wishes or solely on the medical component of what's going on with the patient, but it's really taking into consideration all of these different factors. And an SDM needs to show signs of consideration of all of these factors. And some thought or some weighing and balancing of all of these factors and acknowledgement of all of these factors. What I've also noted too in some of my own reading of reasons is that its best interest is really defined in the context of a specific patient. So in one set of reasons, it describes the patient's own best interests. So we're not talking about best interests of some other standards that we've heard, like a reasonable person standard, but it is really honing in on the patient that's in front of us and what would that patient in front of us, what is their condition and what are their values, beliefs, and wishes, and what's their prognosis, diagnosis, and all of those different considerations. So some of the things that we talk about in family meetings and some of the questions that we propose are, how do we collectively think about the patient's quality of life, for example? And is there a net benefit or harm when considering patient's well-being and continuing on this treatment, for example? And quality of life can be quite a nebulous concept. Some want to do away completely with that concept, but I think that there are some very important components that we can talk about, such as meaningful interactions. And what does it mean to have a meaningful interaction? The frequency of those interactions, is it, once a day for 5 minutes, or is it all day when you have someone in the room or when family members are present? The ability to enjoy things that matter to the patient. I've heard that being able to participate in religious activities, for example, can be very meaningful to a patient. So being able to read scripture or to listen and hear scripture is important. Or food is of huge importance to some folks as well. So the importance of taste. So it can be very individualized when we're talking about quality of life in that sense. And on the flip side, we have to consider and take into consideration some of the harms of continued treatment as well. And this can include pain, discomfort, recurrent infections, significant wounds, contractures, grimacing or crying when being touched, for example. So lots to think about in terms of best interests, and ideally lots of good conversation to work through this. So in sum, when we're thinking about best interests, when we're speaking about this in family meetings especially, we take into consideration balancing sort of the subjective, so the values, the wishes, and even the experiential factors that the patient currently has, in addition to medical probability, evidence-based predictions. And as far as we've seen, it's not necessarily definitive that one overrules the other, but it's really thinking about and recognizing the fulsome aspect of what encompasses best interest for a patient. All right, with that backdrop in mind, we're going to talk a little bit about tips for working with SDMs. And I think that these tips hopefully are helpful not only in these types of cases that may need to get escalated to, and I'm trying to avoid the word escalation, but may need to go to the consent and capacity board, because we don't want to talk about it as an escalation process, but really as a next step to help with decision making. But these tips can hopefully work for any family meeting, working with any patient family, just to provide, again, good care, compassionate care. So first, clearly establish and document with evidence that a patient is indeed incapable. So doing an appropriate assessment. Often we recommend using the language of the law when documenting as well, in terms of the ability to understand, ability to appreciate. Because we only activate SDMs when a patient is indeed incapable. And we want to make sure that we've done our due diligence. So using interpretation services, for example, if language is a barrier, to make sure that, again, we haven't missed something and that we are in the situation where we have an incapable patient needing an SDM to be required. Another important step is correctly identifying the legal SDM. So making sure we've done our due diligence with the SDM hierarchy and gone through who's the highest ranked. Are there POA documents? Are they validly completed? Are there wishes in those documents? So again, doing our due diligence around the background of who is our SDM or who are our SDMs. Building a relationship with our SDM, I think this is really important, especially given the times we are living through, busy times in acute care settings, and everyone's lives being disrupted with COVID-19, but taking the time to understand our SDMs, what they're experiencing, and how we can best support them. We often forget that they too are going through a lot, our patients are going through a lot, but our SDMs may need some additional supports and resources. And sometimes our hospital is able to link them with the appropriate resources. Being empathetic, recognizing that our SDMs are unlikely to have been in a situation like this before. We come into work every day, we might see patients in the ICU, patients who are connected to machines and technology, but this might be the first time that an SDM has come into the hospital and seen someone in this condition and not quite understand what this is like, and it can find it very overwhelming. So being empathetic to where people are at. Asking open-ended questions about the patient as a person. One of the most rewarding parts of being an ethicist is being able to ask questions around values and beliefs, and who was the patient before they came in here? Tell us a story, one of your favorite stories about your loved one, and just getting to know families. And sometimes I'll say even asking that question, being able to share a laugh or two, sometimes a tear or two, learning about the patient and what they were like prior to coming in, what they enjoyed doing, and sometimes it's just incredible stories about people's lives and how they've impacted other people. So I think that's, again, an important step, not only for these cases, but for any cases. Another question that we do like to ask is to inquire if your loved one were able to be part of this discussion, or if they were here by the bedside, what do you think they would tell us to do? Again, trying to understand better their values and beliefs. Establishing team consensus is also important with the immediate team and with any consultants. We want to make sure that we are providing consistent messaging in terms of the appropriate next steps and what's recommended by the team. If the patient isn't yet in a situation where they're in ICU, for example, and there are discussions around what's appropriate or not appropriate to offer in terms of standard of care, and making sure that only treatments and interventions that are part of standard of care are being offered as well. Some further tips, so clearly communicate, provide education to SDMs on, as I've mentioned before, diagnosis, prognosis, treatment options, alternatives, as well as the principles for substitute decision-making. So they're aware of what are the principles and how one ought to be thinking about making these decisions. It's also a guide, given the nebulous nature of being an SDM. And, instead of asking the question of, well, what would mom want? Really walking through any prior expressed capable wishes, what are her values, wishes, beliefs, how are her current experiences, what are her incapable wishes, and then walking through harms and benefits and all of those. So discussing those in detail, the principles for SDM with the substitute decision maker, and documenting that conversation very clearly as well. Using supports, the interprofessional approach we find is very helpful. Social work, incredible, definitely involve ethics, spiritual care, patient relations. And more recently, we've been, I think, thinking outside of the box in terms of who might be additional folks to support the SDM in decision-making, who might know the patient well and their journey and their story. So occasionally we've had patient's cardiologist who's been following the patient for a long time, or a patient's oncologist who's been following the patient for quite some time, who might have had some in-depth conversations with the patient in their clinic to get a better understanding of what they would want or not want, and has also had the time to build some trust and some strong relationships with the patient and the SDMs to have a more fulsome conversation. There was a case more recently as well where we had the family doctor involved, given their longstanding relationship with the patient, and found that conversation was very fruitful. Nonetheless, we can do all of this work and try to be as compassionate as we can and do our due diligence, but in some situations, we do need to reach out for assistance from an external body to help resolve some of the uncertainty or the conflict that can occur between SDMs and the treating team, or sometimes between SDMs themselves. So that's when we turn to the Consent Capacity Board. I'll give you a brief overview. This is an ethics version of what is the CCB. So certainly reach out to the Consent Capacity Board if you have any further questions around their role and what they do. I will say that in our own experience, they've been incredibly helpful in terms of process questions. And we have invited members of the CCB to do some in-services for our organization from the class that Eoin and I teach, and have found it very helpful for our clinicians. So the Consent Capacity Board is an independent provincial tribunal in Ontario. We're very fortunate to have this, this option as opposed to having to necessarily escalate directly to the courts. Their mission is the fair and accessible adjudication of consent and capacity issues, balancing the rights of vulnerable individuals with public safety. And there's a link there on the screen if you'd like to look that up further. Their key areas of activity are the adjudication of matters of specifically what we've been talking about, so capacity, consent, civil committal, and substitute decision-making. Now, what we're going to talk about today is really focused around substitute decision-making as opposed to some of the other important roles that the Consent Capacity Board plays in terms of, again, civil committal or things like privacy. So again, we're going to just focus narrowly on substitute decision-making. A special thank you to Diane Godkin for putting together and helping us work through this lovely chart. Here's a brief summary of applications that can be made to the Consent Capacity Board related to SDMs. So first, if we have an individual who's incapable, who wants a certain person to make decisions on their behalf, they can apply to the Consent Capacity Board to have a representative appointed, and that's called the Form B. We don't typically see too many of those in the hospital setting. If there's conflict amongst equally ranked SDMs, so let's say you have multiple siblings or you have multiple equally ranked children, and one or more believe that they can actually best represent the patient or best represent their best interests, they can apply to the Consent Capacity Board to be the patient's rep, and that's a Form C. If there's an unranked or a lower ranked individual who is willing or wants to be SDM, they can again apply to be the patient's rep, and that's the same form of Form C. So thinking of some examples, if there's a friend, so they wouldn't be ranked on the STM hierarchy unless they were assigned power of attorney for personal care. But let's say they weren't, but they have known the patient quite well for many years and they want to be the representative, then they can apply to outrank, let's say, a sibling. Or another example is if there's a niece or a grandchild, so any other relative who wants to outrank another person, a sibling, then they can again apply for a Form C. And that niece or grandchild might have been the caregiver, for example, for the patient for a long time and feel like they know the patient better in order to serve that role. If there's a lack of clarity of a prior expressed capable wish, then the SDM or the proposer of the treatment, admission, or service can apply for directions regarding those wishes. That's a Form D. If the SDM wishes to depart from prior express wishes, they can do that through a Form E. And then if the SDM is not thought to be complying with the rules for substitute decision-making, then that's the proposer of the treatment, admission, or service can apply for review of the SDM's compliance with the rules for substitute decision-making. And in our experience, we've certainly seen quite a few Form Cs come through, and Form Gs as well, I would say, are probably the majority. So those are the ones we're going to focus on today. But I will touch on some general notes about CCB applications before I'll let Eoin take things over. So some notes. Form B and Form C applications can only be made if there is no legally appointed SDM. So as you saw with the hierarchy, the top two are a guardian and an attorney for personal care. So if those two are already in place, then it's moot to have a CCB Form C or Form B application because they would already be outranked. For any of the other forms that we've talked about, they all require that the patient has been found incapable of making the decision at hand. And Eoin will talk about the importance of good documentation and assessment if we need to go down the route of a CCB application. And each of these applications automatically triggers a Form A hearing to determine if the patient really is indeed incapable prior to proceeding. In the instance of conflict amongst equally ranked SDMs, so I mentioned a Form C is possible in those cases, The proposer may actually engage the public guardian and trustee as an alternative, particularly if the decision is time dependent. So if one of the family members, for example, or if any of the family members don't want to go down that process of a Form C, but there's disagreement, so we can't proceed without consensus with informed consent, then we can turn to the public guardian and trustee. And I will note too, for Form Cs that there is criteria that needs to be followed. So the incapable person must not object to that appointment. The representative must consent to the appointment, is at least 16 years old and capable with respect to the treatments for which the appointment is being made, and the appointment is in the incapable person's best interests. And Eoin is going to talk you through a case to demonstrate that later. Some other important notes. So the hearing is required, or a hearing is required to occur within a week unless an extension is agreed to by all. Patients have legal representation, which is typically by Legal Aid Ontario. A potential SDM or the potential SDM usually represents themselves, although more recently we have seen SDMs having legal representation. The proposer, if we're talking about treatments, for example, and it's a physician, may wish to have legal representation. Typically that would be arranged if it's a physician through CMPA. On the application itself, an institutional contact is often required. This would be someone to help with the administrative tasks. Typically, in the case of when we used to have the hearings done on site, this would be arranging rooms, for example, and helping guide some of the process. And our fantastic social workers in some of these areas have taken on that role, and we've even had a unit manager also assist. Something else to flag is if interpretation or accommodation may be required, then it's important to flag that in the application for the CCB to give them the heads up so that it doesn't delay any processes. If that's needed at for example, a pre-hearing and that wasn't known previously, it's much better to include all of that information in the application itself. Some high-level takeaways. So some situations might be able to be resolved through the pre-hearing meetings with the CCB. Most Form G cases were in relation to end-of-life decision-making when the SDMs were not consenting to withdrawal of life-sustaining treatment. The CCB has ruled that SDMs did not comply with the rules for decision-making on a number of occasions. And we do have, or I did pull an interesting article that was written by some of our ethics colleagues, Chidwick and all, in the Journal of Critical Care. I think hopefully soon we'll be able to get some more recent data, but the data from 1996 to 2011 indicates that 79% of cases brought to the CCB ruled in favor of the clinician's perspective, whereas 21% ruled in the favor of the SDM perspective. I think things have maybe changed a little bit over time, but it would be interesting to get some of those results. In the cases where the CCB has ruled that SDMs did not comply with the rules for SDM, in those cases, there was often clear and cogent evidence that was documented in the patient's health record related to the patient's situation that, as I mentioned earlier, used language of the law to talk about patient's capacity, prior expressed wishes, if any, and best interests as well. Okay, so now I'm going to pass over to Eoin to keep going, and he's going to chat a little bit about some cases and some other tips on working through these cases. Thanks, Eoin.
Thanks, Roz. Really appreciate it. So hi, everyone. Eoin Connolly, ethicist at Trillium, as you know. I just thought I would go through a few sort of typical cases or hypothetical cases where sorry, the slides are moving there a little bit on me for some reason. There we go. Okay, back to where we should. Thank you. I thought we would take you through some hypothetical cases, which are composite of some of the cases that we may have been involved in, where an application to the Consent and Capacity Board might be considered by the team or has been considered by the team and gone forward. So this was a Form G case, similar to one that we had on the unit where an application was submitted. So Mr. S is married. He's got 2 adult sons. His spouse would be his legal SDM. Actually, I think we're going to go back one more slide, I think. Rods, I don't know. Doesn't seem to be going back for me, Rods. I don't know if you can advance it back. There we go. Yeah. Thanks, Roz. Do you mind if I just ask you to forward the slides? Okay. So Mr. S was admitted to the ICU. He had lost consciousness at home. He has, unfortunately, has advanced metastatic cancer. He's had this diagnosis for a number of years. This admission, he unfortunately has declined somewhat rapidly, and he needed to be intubated, put on a ventilator, and brought up to the ICU. After a bit of time within the ICU, and given his underlying conditions, his MRP, most responsible physician, the intensivist, seems to be of the opinion that he will not be able to be weaned off the ventilator, and he's not likely to regain consciousness under his current situation. The MRP, in preparation for the family meeting, to discuss code status, and also to propose potentially the withdrawal of life-sustaining treatment. The intensivist goes to the chart and reviews it quite extensively to determine whether or not there is a previously expressed capable wish. He comes across a note from the patient's longstanding oncologist where there's been a lengthy conversation and there's documentation that the patient would not want to remain on a ventilator unless there was some meaningful recovery, and that he would not want CPR in the instances of cardiac arrest. He also expressed to the oncologist that he thought his family would find this very difficult. And the oncologist encouraged him to obviously speak to his SDM, which would be his spouse in this situation. But he felt, Mr. S felt that there really they wouldn't be ready for that sort of a conversation. This was, I think 6 to 8 months prior to his admission to the ICU, right? So he was a younger, if you could go next slide, Ross, thanks. He was on the younger side of things, 67, and had 2 adult sons and was married. His spouse was his legal SDM, but she preferred to make decisions in conjunction with her 2 sons present, right? So it was a strong family unit, and they made decisions as a family, but obviously in this case, the spouse was the acting SDM. During the conversations with the family, the family came forward and said, he's still very young. They weren't ready for him to die yet. And when asked and presented to them what they thought of the oncologist's note and what the patient would have wanted, and what we can see is what appears to be anyways, a previously documented capable wish, potentially applicable to the situation. The family really didn't think that he would say that. They thought he was young. He was 67. He'd want to be with his family, and it sort of took them by surprise a little bit, right? One of the sons in particular stated that he really couldn't imagine life without his dad, and they really wanted everything to be done for their father, including CPR if he was to decline further and have a cardiac arrest. The wife, the patient's spouse, and the other son agree and really don't want the patient's code status changed from full code to a no CPR, and they don't really want to discuss the withdrawal of life-sustaining treatments. They're not ready for that yet. So the intensivists felt that they were in a bit of a bind, so to speak. They felt that they really wanted to honor the patient's wishes, but at the same time, they wanted to be respectful of the family and the grieving process they were going through. They didn't want to seem cold-hearted to just then say, hey, no, this is what we have to do. And it was a real difficult case. There was multiple family meetings in this one. And it was challenging, I think, for everyone. In the end, in this case, the intensivist felt that he really needed to follow what he was perceived to be the law and follow the patient's wishes. And he submitted a Form G application to the Consent and Capacity Board in this case. Unfortunately, this is one of those cases that didn't get before the board because within 48 hours after multiple family meetings and submitting the application, the patient did actually have an arrest and passed away and died. So it was very challenging for everyone in this case. But this would be like a typical case that a Form G application would likely be appropriate for. You know, we've got documented wishes, we've got a patient that's incapable, and we've got an SDM that, from our perception, isn't following the principles for substitute decision making, we likely have, you know, in this case, and unfortunately, we didn't have time to go through the CCB process, but we could at least start the process and go from there. Okay, Rosalind, next slide. This is another Form C, and we've got sort of Form C / or in brackets Form G, and hopefully I'll get a chance to explain a little bit what I mean about that. But this is sort of a typical Form C application that comes up at our place on occasion. And it's actually interesting to see, if you look at some of the stats around the number of Form C cases that the CCB has heard, there isn't a whole lot. And like Roz and I are really talking mainly about medicine type cases as opposed to mental health cases. So in the medicine world, there isn't a whole lot of Form C applications that the CCB has heard historically, but I think they're starting to increase. I know anecdotally, I would say in the past probably 3-4 years, we've had, I think, about 2 Form Cs a year that have gone to CCB, which is, I think, substantially more than the CCB has heard in the past. And I think it's really important to make SDMs families aware that this is a potential venue or avenue or process that can be tapped into and resolve some of these conflicts or challenges. So we've been, I don't want to say promoting it per se, but we've been making people aware of that it's a process that they have an option for. Right? So in this case, it was a 42-year-old female who was involved in a motor vehicle accident. She suffered a severe traumatic spinal cord injury, as well as had an anoxic brain injury due to a cardiac arrest. She was divorced, but did have one adult, arguably adult child. At the time of the accident, the child was a teenager. And so if you go back to just recalling the hierarchy that Ross had set out earlier, you know, the patient's father, because the mother was deceased, the patient's father would actually be the highest ranked SDM. The patient hadn't completed a power of attorney for personal care. At the time, there was not a CCB representative appointed. There was no guardian of the person. And so the child, the teenager, was only 15, and to be an SDM for someone else, you need to be at least 16, right? So initially anyways, the patient's father was the SDM, assumed decision-making authority. Eventually, the patient did become ventilator independent, did become bed-bound, and was in and out of the ICU on numerous occasions. So next slide, please. Now, there was some family dynamics within this family. When the teenager actually turned 16, they did express a desire to become more involved in the decision-making of the patient, much to the chagrin of the patient's father. According to the hierarchy, the father and the child, who's now 16, would be equally ranked SDMs. And just to clarify, it's not majority rules. In this case, it would be 2, but generally speaking, if we've got equally ranked SDMs, it's not majority rules. It's not the favorite son. It's not the oldest daughter. It's not the physician in the family. You know, it's really consensus-based decision-making for equally ranked SDMs. So they all either have to agree or they all have to disagree in those situations. Things I can say, unfortunately, were not going well for the patient. They were chronically ventilated, had extensive pressure ulcers, and had recurring infections on a very regular basis, even to the best of the care that was being provided. And so soon there became a conflict between the parent of the patient, the father, and the child in their decision making, or the 16-year-old. And this resulted initially in for one instance, initially it went to the public guardian trustee for a very, arguably minor treatment decision about a medication. But we realized that quickly that this was not going to just be one minor treatment decision that there was going to be conflict over, and it was going to be an ongoing basis. And we made the teams or the family members aware of the CCB Form C application process, and both individuals submitted competing Form C applications. Just to give you a bit of an outcome of this case, it did go forward. It was heard. And in some of these cases, this is why we have the G in brackets. When you have competing Form C applications, they do, I think, turn into maybe informal Form G applications, because they want to know who's going to be, CCB wants to know who's going to be, the best SDM. So who's going to follow the principles for subsequent decision making, who is going to know what the patient would have wanted, is there a previously expressed capable wish, and if there isn't a previously expressed capable wish applicable to the situations, who's going to make a decision that's in the patient's best interest. So there is usually, in some of these cases, a best interest analysis and a determination of which SDM or which potential SDM is going to do what's in the patient's best interest, right? And we can't decide who's going to do what until we know what actually is in the patient's best interest. So in many cases, these Form Cs, when they're competing with multiple applicants, turn into a Form G application as well, although informally. It's not a resubmission or anything like that. It's through the process of deciding who's going to be the SDM that the principles for substitute decision making need to be considered, and it often goes back to that best interest standard that Roz was talking about earlier. Okay, maybe next slide. So as much as we love the CCB process, there is some hesitancy from the clinician side of things, or from the healthcare team side of things, to engage in this process. And sometimes it's not even just hesitancy within the healthcare team, but even amongst family members to engage in this process. So from a healthcare professional standpoint, hopefully the team members won't mind me speaking on their behalf. I think there's worry that if we engage in this process, we're going to dissolve the trust that the family may or may not have with us, and that it will make things more difficult to deal with the family. It'll escalate the situations, make things more adversarial, and it just won't be pleasant for anyone. And I think from our experience, that hasn't necessarily been the case. Unfortunately, when we do take these cases forward, it's likely, from a Form G perspective anyways, it's likely become adversarial already, unfortunately. Maybe it's something we strive not to do, and we try not to present it as adversarial, but it's usually there's been a long-standing, attempt to resolve these disagreements around the treatment plan with the SDMs, and we have not been able to get resolution there. So it can be fairly challenging in some of those situations. But I don't believe that any time that we've actually submitted a Form G application that things have gotten worse necessarily. I actually think it puts a bit of a process in place, but we can talk to that in a few slides ahead when we talk to the benefits of going to the CCB. So I think ongoing interactions with the SDM and family are highly likely, and I think for the most part, it doesn't escalate things. Some family members are hesitant to, if it's conflict within the family, to actually go through that CCB process as well and file their Form C. They don't want to rock the boat in the family. It's a trying situation already because they've got a loved one that's ill, and they really don't want to make things worse from their perspective. Something that I've stressed, and I think the rest of our team stresses as well, is that yes, these situations are difficult for families and we empathize with them, but really it's about the patient, and we need to do what's best for the patient. So trying to really put the focus back on the patient. The timeline and the stewardship issue is a big issue as well. Can be a very time-consuming hearings. I think if there's good preparation, I think that does a significant amount to reduce some of those time constraints. And I think with good legal representation, I think that helps reduce that as well. And I think if you set the groundwork for these hearings ahead of time, and do some of the things that Roz talked about earlier, in preparation for just working with SDMs generally, I think that can go a long way. And as much as we think that these CCB hearings can take up a lot of time, I think repeated family meetings and repeated time trying to explain things to the family, not that we shouldn't be explaining, we should obviously be explaining to the family, but you can have a lot of drawn out family meetings that you don't get anywhere for months, weeks to months to sometimes even years. And so I think the CCB process is definitely more expedient comparatively. CCB hearings can also be somewhat intimidating when it comes to the professional judgment and competency piece. You are being, for the healthcare professionals that are involved, they're often being questioned about what actually is in the patient's best interest. They're being questioned about their processes or the hospital processes. They're being questioned about sort of defending their finding of incapacity. And sometimes, not to disparage lawyers or any way, but sometimes they're not always the nicest in the questions that are and the way they're asked. As part of, I think, the process, I think it can be a little bit challenging for some of the healthcare professionals. But I think if we look at it as, these are people that are really trying to advocate for the patient, for their client as they best see fit, and not to take it personal. And again, if we're doing everything that we should be doing professionally, we should have no issues defending what we've done. Next slide, Ross. I think we might have to fly through these things a little bit. So benefits of engaging in the CCB process. So I think it creates a greater level of awareness and accountability amongst the SDMs. When it comes to, it really helps them, I believe, focus on the principles for substitute decision-making. So if we've had conversations about the principles for substitute decision-making, we've provided the SDM brochure that we have at the hospital, and I'm sure most other organizations have as well. They have a tendency, some families have a tendency to still not necessarily pay as much attention to those. So sometimes these CCB hearings really focuses and sort of makes people laser in on what the principles are, right? Because that's what they're being asked about. It can alleviate some moral stress or anxiety amongst SDMs. So sometimes I don't want to say taking the decision away, but sometimes having another body make a decision or direct an SDM to consent to a certain plan because they haven't been following the principles of decision-making, that can alleviate some moral distress around some of these end-of-life decisions. Also, if you're a family member and you have been sort of agreeing to something with another equally ranked SDM that really doesn't feel like that's what the patient would want, engage in this process can sort of liberate you from some of those decisions that may not be comfortable with you. The third-party mediation, I think, is not a bad thing at all. I think it's a very good thing. It's external to the team. So sometimes the healthcare professionals feel like, hey, it's not us. We recognize that we're in conflict and somebody really needs to work this out. And this is the party that we go to help work that out. Having a lawyer appointed for the patient, for the SDMs. Now these days, the board is appointing lawyers for SDMs, as far as I know, can also focus the process. Sometimes we do have families that when it's difficult end-of-life decision-making, they really don't want to meet with us sometimes, unfortunately, or they find those things challenging. So we really need to go forward and, the lawyers show up usually on time and come ready to talk about the issues. It provides a pathway too, I think, for the resolution of some of these really intractable cases. I think if we go through the process, we feel like we've done everything that we can do, and we're not getting where we should be getting, and so we go to the CCB. Even I've heard from some healthcare professionals where they brought these cases forward, and CCB ruled that the SDMs were following the principles of substitute decision making, so not arguably in favor of the healthcare team. That was still okay with the healthcare professional. They feel like they needed to advocate for their patient, and they did everything they could do. And the CCB has said, no, we think the SDMs are doing what they should be doing, and that's okay, because it still means that they did what the healthcare professional feels they did what they should be doing as well. Right? It can reduce the number of arguably unproductive family meetings. And it does bring people to the table, because if you don't show up to these meetings, there is some leeway with CCB, but from my experience, things get rescheduled, and if people don't show up on multiple occasions, then the hearings tend to move forward if parties are not present without a justifiable reason. CCB also can avoid that lengthy formal court process, which some of these cases historically have gone to. That can play out over years. I think we have to be aware too that the CCB decisions can be appealed to Ontario Superior Court. Okay, next slide, Ross. From an ethics lens, I really do think we advocate by using this process. It attempts to promote the autonomy, non-maleficence, and beneficence of the patient. We're trying to either advocate for respecting the previously expressed wishes of the patient, or what we think is the patient's best interest. So from a non-maleficence, beneficence perspective. And usually if someone has submitted a Form C, they're doing it for the same reasons. They're doing it because they want to respect the autonomy of the patient, and they feel like somebody else, the other SDM, is not doing that. I think the difficult questions about responsible stewardship, they can be a long-term case in some of these cases, and I think the appropriate, making decisions in the best interest of the patient or based on the previously expressed wishes, I think is the responsible thing to do. They're obviously very complex and long-standing in some of these cases. So anything that we can do to promote the dignity of the patient, I think, is very important as well. From the justice piece, I think from a procedural justice piece, I think the CCB is positioned excellently to resolve some of these cases. I'm just looking at the time, Roz, we may need to keep on going. So tips for ensuring just resolution. I think educating the SDMs or potential SDMs about the principles for substitute decision-making is very important. Also, making sure that we've provided them with the same information that the patient would require to make an informed decision. Genuine attempt at conflict resolution prior to CCB, I think, is very important. Documenting that, I think, is also very important. Educating the SDMs of the potential SDMs about the CCB process. So CCB does have, and it's in one of our later slides, the CCB does have some resources on their website that we often give out to family members or SDMs that would be applying or would be part of the process, just so they have a better idea as to what's going on. Good evidence. CCB can only make a ruling on the evidence that is provided to them. So I think on both sides of it, I think making sure that don't complain about the process if you haven't given the information that the CCB needs to make the appropriate decision. And good documentation. So documentation capacity in all of these cases is also very, very important with reference to the legislation. So, the ability to understand and appreciate is very important, and documentation as to why the patient is unable to do that is important, and using that language of the CCB. So applications can be an effective tool for timely resolution of some of these ethical issues. It's an independent tribunal, as you know, all are aware, to address any of the perceived biases, either perceived or actual, from the providing team. There are some of the resources, great stuff on there, and we'll throw it over to Andrea for the last couple minutes.
Yeah, thank you so much, Roz and Eoin. That was a wonderful presentation. Lots of information certainly to process and digest on our end. So some thank yous have certainly come in, and there's a couple of questions. And I know we won't get to all of them, but maybe we can just get to a couple at least. I know it is 5 p.m. One of the questions that came in is, I believe, in relation to the first hypothetical case, maybe that of Mr. S. My apologies if I'm misremembering the letter of the last name, but wondering whether the team performed CPR until the patient died. And this was the case where there was that conflict. The patient had mentioned no CPR and the family had a hard time believing that, and the patient died before the CCB hearing.
Yeah, good question. So in this actual case, the CPR was not performed. It was after the CPSO decision or revision of their policy to allow the MRP to make in the moment bedside decision whether or not to provide CPR. So it had been expressed to the family that we didn't think it was appropriate, and it was arguably outside the standard of care. But the patient was still a full code on the chart. But in the moment, because they were in the ICU and because there was intensivists around, they were able to make a decision not to provide CPR.
Thank you so much. And there are a few questions coming in, so we'll certainly email them to you for your own reflection. And I would encourage people who do want a response from Roz and or Eoin to email both of you. Your email's up on the slide, which is great. So thank you for that. But one quick question, hopefully quick, I believe, is around POAs and whether the forms, the CCB forms, can also be used for POAs, or whether POAs are actually exempt from using the forms or having the forms used on them in relation to their decision making.
Yeah, I can start off with answering that question. So hopefully a quick response. When it comes to the form C, the response would be no, because powers of attorney or attorneys for personal care are higher ranked on a hierarchy. So it would be sort of moot to make an application, since that wouldn't outrank an attorney for personal care. That being said, if someone is an attorney for personal care and assigned, and the healthcare team have concerns about how they are making decisions in relation to the principles for substitute decision making, then certainly the healthcare team or the proposer of the treatment can go to the consent capacity board under a Form G and have the review of how they're making those decisions and whether or not they're complying with the Act.
Thank you so much. And there are a couple of people also asking for references in relation to the cases that you noted, I believe, at the beginning of the presentation, Roz. So perhaps those folks can actually email Roz and Eoin directly, and then those case references can be provided in addition to everyone else. Unfortunately, so much to talk about when it comes to this topic, so thank you for coming. It is time to draw today's seminar to a close, and so I have a couple of very fast announcements to make before we formally speak you. We will have a break next week from our seminar series, and we'll resume on March 23rd, where Andrew Jameson will be discussing bioethics for the Anthropocene. And to sign up to receive weekly seminar reminder emails, please email jcb.info@utoronto.ca. I believe that was posted in the YouTube chat. And CSB students enrolled in the CSB Student Seminar course, please do remember to keep track of your attendance. And so on behalf of all of us, Roz and Eoin, thank you so much for taking the time to share these insights and your expertise. We really appreciate it.
Thank you, Andrea.
Thank you, Andrea.